Actually fortunate enough to attend the first Congress last year, which was held in Copenhagen. It was quite wonderful, and I actually say the best part of it was just getting to network and meet with people and listening about the research around the world. And it's fascinating to understand how we face the same challenges around the world and how we can be learning from each other. So I think that's really a major part of this program. I come from Albany Medical Center, which is located in upstate New York. It's a 716-bed tertiary facility. It's also a private medical school and research center. There's actually only 4 private medical schools in the United States, and Albany Med is one of those. And we also happen to be the busiest trauma center in the state of New York. Frequently, people think about New York City and trauma being very busy, but we cover a very large area, as I will show in a moment. In 2018, we had almost 4,000 trauma patients come through our medical center. If I can turn the pages. Of those nearly 4,000 patients, 91% were blunt trauma. So again, the majority of the trauma injuries as opposed to penetrating injuries. And of that 91% that were blunt trauma, 41% were female. Female have a much higher rate of blunt trauma as opposed to penetrating trauma. Albany Medical Center is located where the star is, but you can see the region that we cover, so that we go all the way up to the Canadian border. We actually take in part of Vermont and Massachusetts, and we go down close to the Westchester area and out west. So we actually cover and provide services to 25 counties. Why a study about suffering? The important thing to ask yourself is, you know your patients are suffering, but do you know why they are suffering? Do you know how they are suffering? Do you understand that your care can make their suffering better, but your care can also make their suffering worse, or your inappropriate care can make their suffering worse? And are you caring about your patient when you're caring for them? We can get into the technical tasks, and that's a lot of caring for the patients, but are you actually caring about them? This research actually will hopefully help to answer some of those questions. This research actually builds on the original research that I presented last year in Copenhagen, which was a study on men. This is a follow-up study on women. The whole concept of suffering, though, goes back to as far as Aristotle and Plato, in which suffering is something that one who bears even our word patient comes from and is associated with the experience of suffering. And originally it was really understood as something evil. But it has really moved on, and it was in 1982 when Castle did his initial work in identifying really what is the substance, what is the basis of suffering, identifying that it really comes as a result as a threat to one's sense of wholeness. And as that, suffering results because your beliefs and values are put into doubt. Everything that you knew or you thought you understood is questioned. The other thing that's important to understand about suffering is that very personal. It's very different to each individual. It is also multidimensional, and the research again helps to support that. And it impairs, again, a person's connectedness, beliefs, and values, and we see how that impacts and results in their suffering. But suffering is something that can be made bearable or unbearable, and nurses play a significant role in both of those directions. Blunt trauma is also important because this is something that can be experienced by anyone. Any socioeconomic status, any occupation, it can occur to anyone. It occurs more frequently than blunt trauma, given the statistics I just shared. This was again going back to 2015 from the National Data Bank. Suffering is a complex phenomenon that is central to every person's health care. It's important to nursing because it is why we interact with the patients, to provide care and that caring. But there is truly a lack of understanding about suffering because most of the research that has been done in relation to suffering has been done in relation to terminal diseases, patients with heart failure, renal failure, strokes, that are going through the dying process. And these patients have had time to get their diagnosis and understand it and process it, as opposed to you being the healthy person today, getting hit by the bus tomorrow and being totally compromised. You are totally unprepared for that whole experience. And with today's technologies, there's an increased risk, or an increased, not risk, increased probability of survival. So undertaking this study, I used a phenomenological approach because we wanted to understand the experience of suffering. And after getting reviewed by the IRB committee, surveys were sent out, or questionnaires were sent out to potential participants. I went through the database to identify women who had had blunt trauma injuries within the previous 12 months that were discharged from the hospital alive. I also made sure that they spoke English as their primary language, because again, they needed to communicate well their experience of suffering, and so I needed to really understand it. So it really needed to happen in English. The interview process was actually recorded with the permission of the patients. Those recordings were then transcribed, and each patient got their transcription back, and they were able to go through and change everything, anything that wasn't correct. That really helped to increase the validity of the research study. After the analysis was done using the NVivo 12 software, and if you've not used NVivo for qualitative analysis, it is really a wonderful software. And if you happen to be in school and you're also having to do a literature review or something, using the NVivo software is a great way to do and track your literature review and make it also synced and things. So it's a pretty exciting software. And then the results were actually sent back to the participants so that they could also give feedback on them and hopefully to identify them. For this study, data saturation was actually achieved with 12 females. They ranged in age from 21 to 71, and their injuries had occurred in the previous 12 to 6 months. You can see most of these were falls. All of them had fractures. Most of them were falls. There were a couple auto accidents, the MVAs, and a bicycle accident. Most of the patients ended up going home after being discharged. 2 had gone to an inpatient rehab for a temporary period of time. The 4 main themes that really came out from the study was identifying the original threat to wholeness, that is, what caused their original suffering, that is, who were they and what was compromised, and that related to their activity and independence, work, or family. Those roles, that meaning was threatened, which began their experience of suffering. Their normal patterns were then disrupted, which also then manifested itself as suffering, physical suffering, emotional, social, economic, and spiritual forms of suffering. Through hopefully a supportive process, they began then to regain that sense of wholeness. And there were intrinsic and extrinsic factors that impacted and made that ability to regain either better or worse. And then at the end, they actually end up revising their wholeness, so they came away with a whole new sense of who they were. And this is the model from the research, and we'll go through the different elements of this. First thing was the threat to wholeness. And to really understand this, you have to understand the person. So you have to be able to begin dialoguing with them and understanding what's important to them. As a part of the interview process, I did not ask questions about what was important to them. It actually came from the way they were responding to other questions that you began to understand what it was that they valued. And it fell in basically to 3 categories. What really helped define them was their activity or independence. That was most important to them, or their work, or their family. And this situation threatened those things, which began their journey of suffering. This again is just sort of identifying the breakout, and so people could have more than one thing that they were defining themselves. So especially family was an important one. While they also think of themselves as an individual and that independence, family was equally important, and when that was threatened, that contributed to their suffering. So suffering, again, really results because of a disruption to the patterns of suffering, because of this mutual interaction with the environment. But again, it is now being destructed, and we have to figure out how to do that, how to address that. And again, this is showing the relationships. The most frequent form of suffering was physical suffering, and equally emotional suffering for the women. Physical suffering was most significant for men, and emotional was only slightly less for the men. But then the next became, after physical, emotional, the social suffering. We'll go into more details on that, economic suffering, and then spiritual suffering. Physical suffering came in a variety of different ways. Again, if what they were really valuing was being active and independent, that now lying in a bed or staying at home because of your fractures and waiting for them to heal, that immobility resulted in significant suffering. Pain was also a significant factor. What was also interesting in the women were much more eager to get off of pain medications than the men were. Part of that was because the women were kind of sensitive to some of the medications, and they experienced more nausea and things with some of the medications. They said they just didn't make me feel well. I think another part of it is, on the time of this study, the whole opioid issue is going on. And so again, I think there's a heightened concern about how quickly to get off the medications. Sleep disruption, as the patients say, no one gets to sleep in a hospital. It's not a restful place. But again, there are a variety of things that contribute to the sleep disruption. Because we're treating the pain, we also end up with constipation. Now, we have technology and medications that can help to address that, but we don't do a good job. And for some of the patients in the male study and also in the female study, they were saying the experience of constipation was worse than the pain and suffering from some of their fractures. Not only the physical discomfort, but the other interventions to take care of it was just totally demoralizing. And for the women, unique, unlike the men, personal hygiene was also a significant factor that contributed to the suffering. The emotional suffering was equally important. And the sources for this is, for most of these people, this was their first injury, their first time. So this was a new experience, which led to so many unknowns. You had no idea what was going on, no idea what to expect. So there was a lot of doubt, worry, and concern. New situations, new interventions happening to them. They were also out of control, not being able to control what was going on, and they enjoyed that control, and now they've had to totally give it up. That resulted in the occurrence of depression under emotional suffering. Also, change in role. Again, a lot of these women were mothers or in relationships, and that role changed as a result of these injuries and their recovery, and they weren't always comfortable with that role change. It was really much more significant for the men, who were used to being very independent and sort of the controller, taking care of the family. And for the men, they were totally threatened when, for the first time, their children were actually seeing them compromised and maybe not superheroes. The women were much more comfortable with that. But again, these unknowns also then ended up leading into anger. The loss of control and helplessness or dependency, again, contributed to the emotional suffering. And it's important, as we begin to understand these things, when you know these things, it then begins to help you know as nurses what kinds of things you can do to help alleviate the suffering. So again, in these situations, if it's loss of control, how can we begin to give the patient back some control, some decision making that they can make at that time to help address and mitigate some of their suffering? One of the other things that Castle had identified is that patients are not always aware of their suffering, although they are suffering. That was demonstrated in the study of men. It was also demonstrated in the study of women, that actually as a part of this interview process, and they began to reflect on their experiences, they began to identify suffering that they weren't even aware of at the time, but looking back upon it, they did appreciate it as an experience of suffering. Social suffering occurred because of changes in the normal social interaction. And that began with hospital staff, family, and friends, and also this role change in relation to dependents. Again, they're used to these social interactions. Some of the women reported this being compromised at the time they were in the emergency room, in which there would be certain staff or employees coming in that would not look at them eye to eye. They didn't develop that relationship. They didn't want to connect. And in fact, one of the most probably embarrassing things was, we are an academic teaching center. One of the patients responded that some of the medical students were coming through the ED and came in to talk to her because they were trolling for patients. They wanted to find some interesting patients. And she obviously perceived they weren't caring about her. They were looking for interesting cases. And so she quickly had them removed from the room. Socialization is also impacted because, again, this decreased mobility. You don't have the ability to get around quite as easily, and so you're not getting to do the same kinds of routine things. And so, again, one of the responses was everything flip-flopped. And when I say everything flip-flopped, one of the major experiences that both the men and the women had were changes in their relationships with friends. People who they thought were close friends after the traumatic event didn't rise to the occasion, didn't show up, didn't help, and it significantly compromised that relationship, that social relationship. So again, getting back to everything that they knew before was threatened, which was again resulting in the source of suffering. However, what they also experienced was people who they didn't necessarily know did show up, did rise to the occasion. So one of the things that also came out of this was new friendships and new relationships. Economic suffering. Economic suffering was not as significant for the women as it was for the men. All of the women did have insurance, but they did have additional expenses that weren't being cared or covered based on some of the equipment that they needed, or for the women, getting child care to help support while they were injured. And most of them were able to return to work, which again helped to address or minimize their economic suffering. In relation to the men, one of the most significant things that we had notified or identified under economic suffering is the use of the helicopter. Because we are the Regional 1 Trauma Center and we cover 25 counties, they will helicopter the patient in. Some of my patients in the study were unconscious at the scene of the accident things, in which the helicopter gets called and they get brought in, not by choice by the helicopter. And then they get the $40,000 bill for the helicopter ride. $40,000. And they're saying, I didn't ask, I didn't want. And now they're being faced with a $40,000 bill, which significantly contributes to economic suffering. Spiritual suffering. Again, as with the women, as with the men, spiritual suffering was really only experienced by very few individuals. Those few individuals asking, why did God allow this to happen to me? Most of them actually found that their spirituality helped them cope and deal and bear their suffering better. So it really ended up being a positive factor, and we'll talk about that when we get into the factors that helped. One different example is going back to the study of men. There was one participant who was extremely religious, went to Mass every day, very active in his church. And after his accident, no one from the church showed up. No one came. And while that is social suffering, it also impacted him spiritually, because he believed that he had his great relationship with the church, which was very important to him, and from his perspective, the church didn't rise to the occasion to help when he needed the support. So he had experienced spiritual suffering. This is sort of a breakdown then of the different forms so that you can also see the frequency in which the experiences, the different forms of suffering were experienced. With that now, so the patient is suffering and we're in our recovery period in which we begin to work on regaining normal, regaining our wholeness. And there are intrinsic factors and extrinsic factors. The most significant intrinsic factor is simply a positive attitude. Being a happy person makes a significant difference, really believing that you're going to recover and you're going to get better. So a positive attitude and motivation were significant intrinsic factors. Also, the patient's knowledge level. Some people had some previous knowledge about, because again, many of these were mothers, so their kids or something were injured, so they had some idea of what was going on in the recovery experiences and those kinds of things. One of them, though, also had, believe it or not, had just recovered from cancer. She had gone through, had her surgery, had chemotherapy, had gotten that day, she had gone for her clinical visit and was told by her physician she was clear of cancer, and went for a bike ride and it ended up having a trauma. Can you imagine on what a way to celebrate? So she went right from cancer into her traumatic event. But she talked about how her cancer experience did help her during this phase. Again, what we're really trying to do is regain normal through these positive extrinsic factors. Positive extrinsic factors are those people that are around, so your external people, so family, friends, in most situations are important and can play a significant role, not only for the physical caring, but for the emotional caring. So that support is extremely important if it is there. However, when it's not there, it turns into a negative extrinsic factor. And this was really, I think, one of the important things coming from this research is identifying how what we do impacts the care. So we can do some positive things. So if the patient, again, thinking about lack of knowledge and not knowing what's going on, if you're intervening and you're doing an intervention, to be explaining to them why you're doing the things, what's going on, what they're experiencing, so that they can help gain control. So for an example, one patient had a crushing injury and they were getting their pressures measured for compartmental syndrome. So the nurse was routinely going over and assessing pressures to make sure that it was normal and making sure we weren't going to have to do a fasciotomy. However, all the patient knew was somebody kept coming and testing, had no idea what was going on. One nurse finally stopped and took the time to explain to the patient what they were doing, what they were assessing, why they were doing it, demonstrated it on their arm what normal sounded like, so that when they put it on the patient's arm, it also sounded normal. And you could just see the relief immediate on the patient because they now had control. They understood what was going on. And again, they found it very comforting. Making sure that even that glass of water is within reach makes a significant difference. In the male study, one of the participants was an emergency room physician. It was his first time being a patient, although he had been practicing as an emergency room physician for a long time. Avid bicyclist, very healthy, hit by a car, major pelvic fractures. So again, he knew what was going on clinically, but all of a sudden he was now totally dependent on care because of those pelvic fractures. Very painful because they weren't doing surgery to stabilize them. They were just going to wait for them to stabilize on their own. Extremely painful. So every move was critically important. So he began to appreciate how that glass of water just out of reach makes a difference and contributes to the suffering. That whole experience totally impacted and transformed the way he's now practicing and caring for the patient. So he's now caring about them as he's caring for them. During this period of recovery, the patients also begin to reflect, because as humans, we want to find meaning. We need to find meaning in what's going on, and that's part of the ways that we deal and help to make the suffering more bearable. And so this reflection then leads to transformation and the creation of a new normal. As a part of this, again, the study demonstrated that the participants had an increase in empathy for others with injuries or disabilities. So again, it made them more sensitive to what was going on because of what they experienced. They had a new way of identifying those relationships and what was important. Again, one of the participants identified, I'm spiritually stronger and more willing to rely on others. It resets your values. So again, this blunt trauma event totally flip-flops everything, and then it gets reset, hopefully, on the other end. It's also, again, to understand what's going on, we have to have the time to be able to interact with the patient to help them find meaning in suffering. So I'm going to reflect for a minute on probably the first two presentations. The first one in relation to the staffing ratios that was being talked about. One of the things I'm having to advocate for, even within our own medical center, is moving away from the focus of just tasks and how much time it takes to do a task and how you do your staffing based on tasks. Because the nursing presence, the therapeutic use of self, is extremely important. The nurse needs to have time to be available, to be engaged with the patient, to allow them to talk and think and reflect and work this through. That is as important of therapy and interaction as are the medications and things that we're providing. But we have historically not done a good job of capturing that information in relation to our workload. So we're now changing that whole process. Because it's important, if the healthcare provider can assist the patient in finding meaning in their suffering, then they can help them to end the suffering. This is also really building on Selder's theory of life transition, in that they are creating new realities and new expectations by the meaning that they derive from this experience. In helping to bear suffering, again, avoiding the poor quality of care. And again, there were lots of different examples in which you don't answer the call lights in a timely way. The patients don't necessarily understand. We don't always do a good job. The patient is going to expect, well, I'll ask you, when the patient turns on the call light, how quickly do they expect someone to respond? Immediately. And of course they're going to expect someone to respond immediately, because we haven't done anything to tell them not to expect to respond immediately. So one of the things that we've also implemented to help address that is, as a part of the orientation and going through and getting the patient on the unit, making sure that the nurses are informing the patient that while I'm caring for you, I'm also caring for 3 other patients. Therefore, it could take me up to 10 minutes to come in if you need something. So now I'm informing the patient that it could take up to 10 minutes to get a response. And you actually say 10 minutes when you know you can get there in 5 minutes. Because again, you want to manage their expectation. This is like Disney. You know, like when you're waiting in line and it says it's going to be 1 hour till you get on the ride and you get in 30 minutes. And you think, wow, that was really great, but you waited 30 minutes? It's the same concept. If you tell the patient, oh, I can get in 10 minutes, you can get in 5, you're going to exceed their expectations. But the important takeaway is you've given control to the patient, because now you've said it could take up to 10 minutes, and they're not going to wait to the last minute if they need something when they put on their call light. So again, it's those clever ways of how can we begin to be more interactive in a positive way. And empowering patients to make their decisions about care. So if they have the ability to care for themselves, one of the participants, 2 of the participants in this study were actually nurses, and one had major fractures that also had pins that needed to be remained in when they were discharged home, and they needed to be cleaned, of course, on a regular basis. But even while the patient was in the hospital, the patient said, I want to take responsibility for cleaning the pins because it hurts, and I want to do it, and I will do a good job at taking care of it. And again, it was a way of giving her back power and control. Worked really well in that environment, and she went home, never had any infection, great outcome. But again, we gave her the opportunity to take back control wherever we could, which made a significant difference in her experience. But the most important thing is, again, making sure as we're dealing with the physical aspects and we're caring for the patient, that we're also dealing with the emotional aspects and caring about the patient. And again, we can see this reflected in a lot of the articles and research in relation to nursing caring by Watson, Swanson, and Erickson. So again, as I've been talking about the previous research, both the men and the women experienced physical, emotional, social, and economic and spiritual suffering in that order. The physical suffering of pain was a significant source for both, but as I had mentioned, the women seemed to be better at tolerating the pain and were more eager to get off the pain medications. Sleep issues were significant for both. Constipation was less of an issue for women. There seems to be more prior knowledge in relation to pain medication and the risk of constipation. And body hygiene was a significant issue voiced by the females. One of the other examples that I didn't mention is in our hospital, we have beds where the mattresses are air chambers. Maybe you have those too, where the air chambers change in volume every 15 minutes to help decrease pressure ulcers, the risk of pressure ulcers. It sounds wonderful. A lot of our patients tolerate them. But from our studies, we were also putting our pelvic fracture patients on those beds, and we were also putting our patients on those beds that had rib fractures. And so every 15 minutes, we were putting them into pain. And in our typical way, they would start to complain, and the nurses would say, oh no, I have to have you on this bed because we want to prevent pressure ulcers. And of course the patient is saying, but I don't want to be in pain. So again, how do we end up compromising, and how did we have to work to get them to a different kind of mattress? Again, fear, stress, worry, again, was significant for both sexes. Verbalization of depression and loss of control was greater for the female participants. So being able to give them back control as quickly as possible is more important for the women, and also recognizing that their occurrence of depression is more significant. Social suffering was also experienced more for female. It's because I think they were used to having significant social relationships, talking and sharing. And again, those social relationships were significantly compromised. Friends who they thought were very close friends ended up not showing up and helping. And again, that had a major impact on them. The change in role independence, as I had mentioned earlier, was actually more significant for the males than the females. And the economic suffering for the males was more significant. Spirituality actually played a positive role for both and really wasn't significant in either one. Both sexes utilized previous experience and knowledge, again, as intrinsic factors. The female participants had more experience and knowledge from, again, being a caregiver, which actually helped, I think, them bear their suffering better. And again, that newly acquired knowledge, providing and teaching why you're doing the things, plays a significant role. Intrinsic factors such as positive attitude was extremely important. Both studies found that extrinsic factors such as positive support was critically important, but poor care was a significant factor for both studies. Well, how can we help then? What are other ways? So for nursing administration, nursing leaders, using a strength-based model, healthcare providers as extrinsic factors can actually improve, and this is really where you're individualizing the care, going back to the model that you were talking about, in which care is now individualized, understanding their strengths, what control they can take, and how they can really impact and make the decision, so making it more personal. So as you were doing your presentation, I was reflecting and saying, oh my God, this is like right where you are with ecology. Helping patients to, again, bear their suffering by appreciating that this is a unique experience, which means it's unique to the individual. We really have to understand the individual and their cultural differences if we're going to be able to also help to facilitate the interventions to reduce their suffering. Again, the key points are participants identified that being cared about while being cared for was extremely important. And actually, caring is something that can be taught. Some people intrinsically are caregivers, are nurturers, but it is actually something that can be taught through role modeling. So again, while the initial discussion on strength-based interventions was for the administrators, for the educators in the room, understanding that you can actually teach caring by role modeling it with your students is a way of advancing this. So that compassion is actually something that can be learned, thank God. And again, it is through the role modeling. Fear and pain and suffering is not okay for any being to feel intentionally at the hands of us. And again, this is just to remind us that while we have the ability to positively impact and reduce suffering, that we also have the ability to increase their experience of suffering. So in summary, a phenomenological study can be useful in uncovering the nature of an event such as the experience of suffering. And by asking the questions rooted in philosophy, phenomenology can help a researcher in the discovery and description of the experience. This really also aligns with the work of Frankl in the importance of understanding that we need to find meaning, and so our role as nurses is to help our patients find that meaning, to help them best deal with their suffering. Compassion, caring for and about your patients, can help them better bear their suffering, help them find meaning in their suffering, help them be transformed by their suffering, and help them regain their sense of wholeness. To live is to survive, but to survive is to find some meaning in the suffering, which is really what this is all about. I have now made up a lot of time. Any questions? Okay, thank you very much.